Hello, micro friends. Welcome to another episode of Let's Talk Micro. As always, I am so happy that you're here with me. If this is the first time listening to an episode of Let's Talk Micro, well, thank you for choosing it as one of your podcasts. Okay, so last week it was part one of a series of episodes about collaboration between the microbiology lab and stewardship teams. So today's episode is the conclusion, or part two. So this is a conversation, where I am joined by Hannah Creager and Erin McCreary, and they talk about collaboration between the lab and stewardship teams. And in this episode, they talk about things like nudges, cascade reporting. They share examples of collaborations and closing thoughts. So definitely a great episode. So let's go ahead and listen to it. So as we move on, and I'm not going to spend much time on breakpoints. There's many. I have done episodes, and you have done some too, Erin. And so there's plenty of information out there. But I just want to touch real quick on, you have talked about implementing things, and when it comes to prioritizing, right? Breakpoints, they keep being updated, and it has its challenges. So how do you choose what needs to be, quote unquote, worked on first?
That's a good question. When you have a million things to do, what do you tackle first? I think you marry at first and foremost. If patient harm is occurring, that needs fixed first. So safety issues bubble to the top immediately, no matter how big or small. Patient safety first, do no harm. So then, after you've corrected anything, hopefully there's no harm, but we're in healthcare, that's going to happen. So then after that, then you're like, okay, how do we excel? How do we optimize care? How do we improve? I think we look at several things. One, ease of implementation, right? So it's that classic just grid of effort and output. So is this high effort, low yield? Is this high effort, high yield? Those things go to the top. Is this, moderate, whatever? How many patients are going to be impacted? How many labs have to make the change? If 19 of 20 labs are already doing something, and then we discover that one lab just happened to not be doing disk testing, well, then we do a very targeted, quick thing with that lab and get them competent to where the rest of the labs are. If we're making this change across 20 labs and it's going to be a $3 million capital investment and a bunch of other things, then that, goes on the roadmap for longer term. So I think that's what we weigh, is the safety, how many patients is this going to impact, and to what degree. Is there a length of stay metric associated with this? Is getting results 2 days faster going to be able to get patients out of the hospital faster? Because that can really support the conversation to bring technology on, or to get resources or people to do certain work. What's the effort on the lab end? It might take the lab a year. And so if it's going to take the lab a year and they do X amount of work each day, well, then maybe I can layer another project on top of that, versus, like, is it a marathon or a sprint? And if they're doing a marathon, you can probably be working on 3 marathons at the same time. If it's a sprint effort where I need to spend 8 hours a day for 7 days to just do the work, okay, that's all they do for the next 7 days, right? Let them focus on that task, get that task done, and then we can move on to the next task. So that's just a constant dialogue we have of what's possible and who's working on what and when do we want to roll something out.
I think the other thing that's really helpful is if you think about all the things you want to do and you're like, we're going to have to prioritize amongst all those, like, that's hard, right? I want to do everything. But I think starting with that kind of, hey, this is, there's a handful of things we want to do. These are our goals for the year. Those might not even stay your goals for the year, but anytime you're bringing in something new, then you have a very limited set of things that you're comparing it to. Are we prioritizing ahead of this? Is this bumping something else, or is it not bumping something else? And I think it becomes easier to kind of, which one needs to go first, which one is going to have more impact when you're kind of doing these head-to-head comparisons. For me, that makes it easier you kind of say, oh, okay, now I know kind of where this falls. So, and I think that's a good way also of, people for us. And then also when you're talking to stakeholders, right? They're like, well, we want all of it right now. And if you say, do you want that? But that might delay this. And sometimes they're like, yeah, that thing I can wait. And sometimes they're like, oh no, that other thing, do that other thing. And so I think that's a helpful way to think about it.
Yes, definitely. Later on, I'm going to ask you about a specific example that I heard on the Mad ID talk, but there are a couple of things that were mentioned, and we have talked a little bit about suppressing. You mentioned things like cascade reporting and nudges. So maybe for the listeners, we can expand a little bit more on that. Let's start with what is expand on what a cascade is and give some examples of when to apply it or suppress results.
I hate cascade reporting, so maybe I hate it so much. So I think selective suppression is tactical. I think cascade reporting is fraught with error, and I could go on about it all day. But do you want to explain, Hannah,
I
what
think
it
you
is?
gave it a bad name, Erin, because
Yeah.
the principle, right, is that if there's sort of a hierarchy of antibiotics, and this is more true in some classes than others, right? But for the sake of my example, we will pretend there is a perfect hierarchy of the cephalosporins, right? And so the idea would be that if you have something that's susceptible to a first generation cephalosporin, that's the narrowest spectrum. That's what you want to encourage your providers to use. You would report only that first generation cephalosporin. However, if you have resistance to the first generation cephalosporin, you would then unhide the second generation cephalosporin. And then if there's resistance to that, you would show the first, the second, and the third generation cephalosporin. And so that's sort of the idea. I think it is one way, especially if you have a lot of providers that aren't thinking stewardship, they want to just see a short antibiotic list, you can see the benefits. I think it's the things that I don't like about it are, one, it's not as good for someone like being able to look at and understand a susceptibility pattern. And when you have really medically complex patients or patients that have multiple organisms, like we do in some of our centers, that means there's a lot of phone calls to the lab because, oh, actually, I need that third gen Ceph because of this other bug or something like that. And so that's actually something we've sort of compromised as we're looking systematically. We had some of our smaller labs that were more aggressively cascade reporting, and we decided that it was more important for us to be uniform across the system while also not killing the academic medical centers with phone calls all day for releases of ceftriaxone. So our cascade reporting is fairly limited, but we do very much actually do it for some of the newer agents. Think about, we have like one for Pseudomonas with ceftazidime avibactam and ceftoltazone and imipenem-relebactam. And I think that's helpful, one, sort of in, prioritizing our resources for testing. I also think a lot of those drugs, there's not as much familiarity with. And to a certain extent, I think providers actually appreciate knowing, like, okay, just use this one. This is the recommendation. Or, and they're rare enough that we even have stuff that's that resistant that if ID does have to call or stewardship does have to call and say, can you add this on too? It's not phone calls the entire day long.
Yeah, I think, hate's a strong word again. I think, so I'll be more specific. I do think cascading, suppression, and some of these tools for micro reporting get interchanged when people talk about them. And so I do think there's some important and precision in what exactly you're referring to and what you're trying to accomplish. For example, if you have, the inducible AMP-C organisms, Enterobacter cloacae, Citrobacter frundii, and you decide to not report ceftriaxone, that is not a cascade. That is selective suppression of antibiotics that you think are not effective for the treatment of that drug. And that I'm on board with. Like, if you have clinical data and whatnot to show that it's maybe not a good idea, then by all means try to discourage use of that. Cascading, like Hannah described, I guess particularly with Enterobacterialis and cephalosporins and carbapenems and Pt.2, I just think it gets really messy, and I think those bugs are a lot smarter than us. There's a lot of unique phenotypic patterns, and I don't think there's a lot of stewardship gain in trying to like hide ceftriaxone if cefuroxime is susceptible, or hide cefepime if ceftriaxone is susceptible, because there's just so many different iterations of patient care. And then what really burns you is when those rules are built into your machines and then you change your electronic health record, which is what Hannah and I have been dealing with, in that we've basically found that across all of our labs, there's a mix of some people have rules built on the electronic health record, some people had rules built in their machine, sometimes rules are built in the LIS, and then sometimes they overlap and they cross, and you can't actually figure out what rule is making what appear where, and you're trying to update the rules and you can't figure them out. And then the breakpoints change. And so our cascade reporting that some of our hospitals had in place was a nightmare when we had to go back and make sure every lab had actually updated the cefazolin breakpoint appropriately, which half of them had not. And so some people had these cascades in place. And when we basically said we're going to pause and reset and update all of our cefazolin, we were suppressing cefazolin in the short term while we were ensuring the breakpoints were validated. And so labs that had these cascades in place, all of a sudden, just no cephalosporins were getting reported. And we didn't realize that because cefazolin was susceptible in the background, but we weren't reporting it. But then the cascade rule wasn't releasing the other cephalosporins. And so we had a couple days where like no cephalosporins were reported. And then I just think, you write these rules and then people leave and the turnover and whatever. And then untangling them is quite a mess. So I'm just not a super big fan. But Hannah's correct in that we do have a Pseudomonas cascade basically where ceftoltazo gets released if the, basic beta-lactams are resistant. And that's helpful. I mean, that's good medicine and it saves the lab a bunch of calls. That was actually one of our other priority projects that we worked on this year. Is we went through gram negatives and gram positives and we said, okay, what phenotype is going to prompt every lab in the system to automatically set up additional susceptibility testing or send out additional susceptibility testing versus what should we, and what bug and what culture source versus what should we hold on and just have people call to request additional testing? Because, if you have a Pseudomonas in the blood that's resistant to everything on your panel, you're going to need ME-REL, you're going to need cefiderocol testing. The sooner the lab can get that set up or sent out, the better for the patient, right? And so we're like, in those settings, why are we making people call? People might not see it till the next day. It's, then you're 2 days delayed in getting it shipped out. So we're trying to improve patient care by having some of these automatic triggers to set up additional testing too.
Okay, and then the other term used was the nudge.
Oh,
So,
nudges, yeah. Nudges,
yeah,
nudges we
yeah.
love probably too much. Hannah and I love to talk and we love comments. So we're probably over eager on the comments, which is a very reasonable debate about this. Some people are like, stop cluttering up my report with words that no one reads, which that's a fair take, I think, maybe. I agree. Most people probably don't read them, but we feel better that they're there. So at least we can say, hey, the words are there. You didn't read them. That's on you. So I think we both lean toward adding comments. So a nudge essentially would be in the culture and susceptibility report, you have some kind of assessment comment. So it's, it goes beyond just drug MIC interpretation. It's here's how you should apply these results to your patient in some fashion. And that could look like we strongly encourage an ID consult because it's staph in the blood. It could be steno in a respiratory culture is often a colonizer, clinically correlate whether or not your patient actually needs antibiotics. It could be we've visually screened this plate and there's no Pseudomonas on this plate. So this is normal respiratory flora, no Pseudomonas seen. And that can maybe nudge a prescriber to not use anti-pseudomonal therapy. So they're like these little encouragements, little love notes, so to speak.
Yeah, I think we used to just call them reporting comments, but then Henry Ford Health System showed the success that they had with, stating that basically normal respiratory flora didn't include Staph aureus or Pseudomonas, and they kind of coined the term micro nudge. And I don't know if anyone else is doing it, but we've decided to freely apply that to other nudge type comments, like particularly the quote unquote steno nudge, having a comment about colonization. So that's why we're using that funky term.
Got it. And yeah, we as you were talking about them, you said the reporting comments, and those of you that are listening and you didn't, you have it, all depends for like an organism or something that maybe susceptibility testing not indicated, or you have all sorts of comments when it comes to either the workup on an organism or things like that. I know that you mentioned, Erin, on the Mad ID talk that I attended, that right, you give an example of a great example of a collaboration where it was like MRSA PCR and can you talk about that?
Yeah, I love this one because this is something where I learned something and it was like awesome. So we love an MRSA PCR in Stewardship to de-escalate vancomycin. I think at this point it's been widely adopted and widely published. And I think all of our I know all of our labs were doing MRSA nasal screening to some degree. However, 2 years ago, some of them were still using agar to screen and some were using PCR. PCR is obviously days faster than the agar. And so if you're screening with PCR, you can stop Vanco 2 days prior to then waiting for your agar to result. So from a stewardship perspective, we had a goal a couple years ago to get all of our hospitals to utilize MRSA PCRs. And I am a pharmacist, and so I am conditioned to justify my worth in dollars saved always, right? And so, because I can't bill for my services, I don't perform procedures. And so my value to the healthcare system is, can I save money somewhere? So I think we're like, so I was like, well, I want to ask for a fancy test that's much more expensive than the agar. I think the agar is like $6 and the PCR is like 40 or something like that. And so we did, actually, my colleague Ryan Shields really led, and the UPMC Presbyterian Stewardship team led a small study to show the total cost of care is saved, even though the test is more expensive. With the drug savings and the safety and everything like that, you're saving money for each patient case as a whole. And this is where I really feel for my lab friends, because you guys, it's not fair. Like, you always take the budget hit because the tests cost money, but then you don't necessarily get credit for the savings. And I think that's where our collaboration is so important too, because we don't do that anymore at UPMC, which I'm very proud of. We all get credit for the savings. Like, it all goes into, yeah, we spent $3 million, but look at how much better care we took of patients. And like, the whole service line gets credit for that, which is nice. But all that to say, with PCRs, we did this pilot study and we like tentatively approached the lab. And then we did that at one hospital. So brought them onto Hannah's lab, showed the tremendous success. This was like 5 years ago. And then over time, I'm like, okay, every patient at every site deserves access to this care. What's it going to take to bring this on to every site? I know it's going to be expensive. I know it's going to take all this time. And the lab was like, wait a minute. We hate agar. It's so tedious for our technicians. It takes all this time to plate it. They have to go in and read it the next day. It takes up all this space. Like, all these things that are important to the lab, which really, human time is the only thing we're never getting back. It's a very precious resource. So if we can save technician time, we're doing a lot of good. And so, I'm thinking I'm going to have to like fight tooth and nail to bring on these PCRs, and what kidney am I going to sell to make sure the lab can do this? And the lab was like, I'll do you one better. Not only are we like so ready, willing, and eager to expand PCRs for stewardship for pneumonia specifically, how about we go all in and just get rid of agar because we don't like it, and we'll assess our capacity on our PCR machines, and we'll transition surgical screening, infection prevention and mission screening and surveillance screening, and stewardship use of MRSA surveillance all to PCR. And then we had this really cool thing where we worked with the infection prevention team. We said, listen, some of our hospitals are screening every single patient that gets admitted. Some of our hospitals are only screening NICU babies and nursing home transfers and like everything in between. And so it ended up being like this most amazing effort where basically everyone had to give to get. And so stewardship committed to only using the PCRs for the very specific disease states where they have big bang for buck and de-escalating antibiotics, right? We're not going to screen urinary tract infections where the prevalence is not there and the negative predictive value is skewed. So stewardship committed to that. Infection prevention all got together and agreed across every hospital that we're only going to screen on admission the select group of patients. And they came up with 3 or 4 criteria. And like, those are the people that get screened now, and other patients don't get infection prevention screening. So we decreased testing volumes from the infection prevention side. That then allowed us to tell our surgical colleagues, hey, we're going to transition your pre-op screening in both inpatient and our outpatient operating clinic care to PCR. So you get these results so much faster for your patients, which is so helpful when planning surgeries, because that volume was offset. And then in all of that, we're going to be agar free across UPMC by 2026, which so it's like the coolest project. And again, from a steward, if I only thought with my stewardship hat, I would have thought it was going to be this big uphill battle, expensive, yada, yada. And then the labs actually surprised us with like, this is so much better for us. We save technician time, and it helps you think about when you're trying to pitch a project, like all the different things that are important to the project and what you can leverage. Nursing time is another thing. If you spend a little money, but you save nurses time, you're going to get support. You're going to get buy-in for that project. And so it's just really appreciating the whole care picture.
Yeah. And one thing, and I said this before, I do love myself a good plate, and I do enjoy reading my cultures. But when you talk about the agar for MRSA, let's start with the fact that the expiration date is so short. So whether you get, some other media like your blood and things like that, they have a longer expiration date. So those you have to use them. You have to stay on top that you rotate your stock, because sometimes people are rushing and you just grab the first thing that you see, and then next thing you find 4 or 5 stacks that are going to expire in a day, and people are using something that they just got yesterday. So, and then you add to that, right, the looking at the colonies, and like one of them is like green. Is it really green? Let me gram stain it. Okay, it's coccyzal. Let me sub it out. And then the next day you're doing all your testing. So yeah,
Yeah.
I'm not a fan of that one. Yeah.
Yeah.
Exactly. And meanwhile, pharmacies like, can we please take the Vanco off? No, that screen's not back yet.
Yeah, sort of said that you play it and then you have to look at it 24 hours later and then hoping that it's either negative or like clear cut green colonies, and then if not, it definitely takes longer.
I mean, think about the cost. This goes beyond micro and stewardship, but think about the cost to the system if you can't efficiently plan outpatient procedures because you're waiting 3 days for to understand if they need decolonized or if they need different surgical prophylaxis. So patients are being seen, and then I don't know. And I mean, elective procedures are elective procedures. I don't know that we're necessarily delaying because we're waiting on an agar screen, but maybe, right? And so the efficiencies gained in surgical capacity are tremendous. And then the point came up from several of our hospitals that for urgent emergent surgical cases, they don't have time, they don't know, and so they're just giving all those cases Vanco in the absence of having screening results, in the absence of PCR. So that's hugely impactful, and that's where having each aspect of the team talk about the implications from their side help you make a better collaborative decision.
And I think there's more and more lab technologies that are like this. And I think that's why another reason why we really benefit from the collaboration with stewardship is, one, if we want to justify a really expensive test that there's going to be savings elsewhere in the hospital, we need to get folks that can attest to that savings on board, right? So if we're already buddies and we work as a team, that's tremendously helpful. And even beyond that, right, you need the infrastructure to then support the use of a lab test. Because I know that theoretically you could get great Vanco de-escalation off of this MRSA PCR, but if nobody pays attention to it and no one knows about it because the education was poor and they ignore it, then I'm just throwing money out the window. And so, they're really, it takes two to tango. And in more of these cases, right, blood culture rapid ID would be another classic example. I love doing education and stuff, but like I also have to run a micro lab. And so having help with all of that by folks that do this professionally, right, is tremendously helpful.
Okay, and by now with all the great examples, and you have shown how good your communication is, your collaboration, and have touched on a great deal on all this. So when it comes right from everything that we do, we end up learning some lessons, some things that we take back, and so looking at by now the all things that you have done, what's one lesson that you learned from collaborating that you wish more institutions understood?
Oh, thought-provoking question. I don't know. I'm sure I could come up with a better answer if but I guess you don't know what you don't know, which sounds so intuitive, but it's really not. Every day I'm humbled that I learned something that I just didn't think of, didn't realize. And you have to just keep moving in those settings. I think we're very afraid of failure because we're all very high performing, type A people that went into medicine, and you don't want to hurt anyone and whatever. But you can't accomplish big dreams and goals and implement really cool things if you don't take risks and you aren't afraid to fail. And so, I mean, Hannah corrects me every day, and I'm like, yay, I learned something new today. I think you just have to have that attitude, and vice versa. Hannah has emailed me several times with hey, this is such a cool thing. What do you think about adding this? And da da da. She'll send all this stuff and I'll read it and I'll be like, yeah, we can't do that because of this random thing. And I'll call her up. I'm like, hey, we can't do that, but I love where your head's at. And she's like, oh, okay, I didn't think about that. So I wish people, in stepping into this, just don't be afraid to take risks and don't be afraid to fail and don't be afraid to learn something new every day, because that's the whole point, is that you're better at accomplishing things when you learn the perspectives of everyone else on the team and take into account just these workflow things that you don't know. And that even for me, even pertains just to pharmacy workflow. Like I think I understand ID pharmacy pretty well, but I work with over 40 antimicrobial stewardship pharmacists across the system. And constantly we're proposing pathways or ideas amongst ID pharmacy practice. And one of them will say, well, that doesn't work at my hospital because our nurses, go here, or our ED triage does this. And so we can't implement this pathway this way. You didn't think about that. And I'm just like, oh, okay. I had no idea people worked that way in that type of hospital setting. So let's go back to the drawing board. So I guess that be open to the growth every day.
Yeah. And I think communicate till you're blue in the face. I think this is, as Erin was saying, this is a challenge for us because we have so many stakeholders, and you want to get all of them, right? People have been fairly forgiving with our blunders, but it's good to apologize less and do it properly the first time more. And so I think we've gotten a lot better about that, as we've learned from our misses. And I think also genuinely telling people like, yep, we screwed up. You should have known about that. We missed you. Because when people are cut out of the loop and they don't have the information they need, and then someone's kind of like, whatever, that's infuriating. I work in a lab, right? We're cut out of the loop all the time. I know it's infuriating. And so letting people know that sometimes we screw up, but that is not our intention or our goal. And I think that helps people treat us much more warmly.
Okay, and there are some institutions out there that maybe they feel stuck in the way, and sometimes it can be as simple as not knowing that first step or what to do. Like I want to have meaningful collaborations, but I don't know what to do. Maybe anything that you can say about perhaps like a first step they can take to begin some meaningful collaborations?
Maybe you can comment on the micro side, maybe, Erin, but I think from a pharmacy perspective, I'll ask if you can spend a day in the micro lab. Okay. Maybe if you're smaller, we can't always accommodate people right away. But I feel like every time we have someone, no matter who it is, in their micro lab and they sit on the bench for a day and we tour them around and stuff, they come away with completely a different idea of how every single thing works in micro. And we love doing it, especially if they're like actually interested in learning. And so I think you get a 1-2 punch of it's a huge gesture of goodwill and you start seeing a whole ton of stuff. And then that's a really good way. Also, if you're going to sit with someone for an entire day, or maybe with a few people, you end up talking to one another. So we obviously started with a lot of these structures, but honestly, I think some of the most helpful conversations have come out of, stewardship has been coming to the lab for this or that. It's unbelievably valuable.
Yeah. Meet each other in person. And then even, we work across, again, a massive geographical footprint, but I try in every calendar year to visit every hospital at least once, right? To get out there, meet people in person. So you start by starting and just, meet in person, and then you need a structure. So if you don't have a scheduled meeting time, you're never going to connect. It's too hard to make the stars align. And then you're going to find yourself only connecting when there's this terrible fire you have to put out. And then all of your meetings have this crazed frenzy to them and everything's a disaster. So, we have this monthly meeting. They're on the calendars for years to come, and we can always cancel it if there's no new topics. But guess what? That's literally never the case. Every month, it's always the agenda's too full and we have too much to talk about. And so establish a regular meeting cadence, whatever that looks like for you, whatever's best, whether it's in person or virtual, but establish that meeting cadence. And then as stuff comes up, just throw it on that agenda. And that helps you then have this constructive planning, and everything's not always in email and a fire. And that's something we actually work a lot on, is like really important conversations shouldn't happen over email because they get lost, right? They should be in a structured meeting with minutes. We can reference them back. We can save them in whatever, we use Microsoft Teams, but whatever file sharing thing your organization uses. Create some institutional memory to the conversations, track it. that kind of stuff. So that's what I say, and completely agree. Both when I started at UPMC back in 2018, it was a different micro lab director then, but I spent a ton of time down in the lab when I first started, and then when in my residency, that my whole first month I spent down in the lab. And a good example I like to have of that is we did the no staph, no Pseudomonas screen at my residency site on the respiratory plates, and I was in the lab and I sat with the respiratory bench all day, and I noticed that was the last thing the respiratory tech did before they went home was they would do all the no Pseudomonas screens and then go home. So they did all the other work all day, and then they had their stack, and then they did their no pseudo screens and they left. So the no Pseudomonas comment went in the chart at about 2:30 p.m. Then on my next rotation, I'm rounding in the ICU, and I would hear the ICU intensivist say, well, they would literally write in their progress notes, wait for rule out comment and then de-escalate. It became culture, right? And I realized, I'm like, oh, they truly will de-escalate these patients as soon as that says no Pseudomonas in the chart, but the lab does this last. They put it in the chart at the end of the day. And so then I walked down in the micro lab, and now I'm friends with the respiratory tech and friends with the director. And I said, is it possible from a bench workflow standpoint for you to come in and do the stack of respiratory screens first? So the comments are in the chart by 7 a.m. and then do the rest of your work? And they were like, sure, that's fine with us. We don't care when we do it. I'm like, oh my gosh, because then it would be in before ICU rounds, and then all these patients would get a whole day less of antibiotic therapy. And the techs would never know that, right? How would they know the timing of the day can impact so much? And so you learn a lot of that just by being present and by shadowing workflows and things like that.
Yeah, I completely agree. And something so impactful, and that's what it took, that you being there and seeing it, and then so it's very important.
Yeah.
I do,
and that's a zero cost intervention, right? That took nothing other than understanding how people do their work and collaborating on the best way, place, and time to do the work you're already doing. So those are. And I imagine, honestly, that happens in so many places, and you just, again, you don't even know to explore it. But those are really simple fixes.
Yeah, definitely. So this is a question that I love asking, and I love getting all the responses, and they're so varied and for many reasons, and I have some good ones recently. So right, we all have that bug that we like for any reason. It has that significance, either wrote a paper about it, or that was your PhD work, or there's a mechanism, or just the way that it looks on the plate. It's pretty. Some of them are like that. You get nice colors. Maybe we shouldn't, we don't smell plates, right? Shouldn't be smelling plates, but maybe like a smell or something. So we have that favorite bug. So I'll start with you, Hannah. What is your favorite bug?
Well, it's funny. I feel like in the clinical space, I have more least favorite bugs that either causes problems in the lab or that I have to tell people, I'm sorry, I can't think of an antibiotic to test that's going to help your patient. I guess this is where I unmask myself as not a born bacteriologist. My PhD is actually in virology. Viruses were my first love. I did my PhD in flu. But if I had to pick a microbe, I would say human immunodeficiency virus. It has so many dang tricks up its sleeve that I have a lot of admiration for it, although certainly not happy with all the destruction it has caused.
Hannah, I didn't know this about you. My favorite organism is also a virus. I didn't know that. I was like, no way. CMV is my favorite infection virus, everything about it. Anyone who listens to this other podcast I host will know that I talk about it a lot. I think it's so intricate and complex and so fascinating. And I think the interplay between the virus and the host, much is so tremendous. And then from a pharmacy standpoint, we don't have that many drugs, and the drugs we have are all kind of terrible, and they have, unique PKPD and side effects, and there's a lot of pharmacotherapy there for us to manage. So, CMV is my favorite infection. But again, it does feel weird. It's so terrible. We're a weird breed, guys, because the things we love are terrible for patients in general. But someone has to help them be better. So
Absolutely.
Yeah, and I talk about that here, and I mention it to my students, and it is something. But you open that incubator, and for example, with me, something like an alkaligenes, that smell hits me, and it makes it, I
Yeah.
think it's gonna be a good day today, and
Yeah.
it's just you doing
it's gonna
it.
be a good day.
Yeah,
I love
and
that.
Yeah,
Oh,
you
yeah.
understand the significance of what you do, but sometimes you're seeing the same things over and over again. When you get that excitement or something that you have only seen on textbooks before, it's such a great feeling that you get to see it on the plate and work with it and learn it. So it's just one of those
Yeah.
nerdy things. Yeah.
Every time it's like Raffia mucilaginosa for me. Like it just looks so dang cool on a plate.
Yeah.
I don't think I'm ever going to get over it.
Well, or like I had a pharmacist the other day text me, and the blood culture rapid identification system was no target detected. The patient had come in with an animal bite, and she was able to recommend rapid de-escalation to Unison because she's like, it's going to be Pasteurella. And then she texted me, it was like, spoiler, it was. And like, and I'm like, see that, like all the pieces of the puzzle, like that's really cool about what we do. So
Yeah, that's my favorite one, Pastorella. But yeah, so one thing that before we kind of do the closing thing, and if you have any closing thoughts, I like how you say, Erin, like so quietly, this other podcast that I host, but it's one thing, today that I am, not only I have awesome micro ID people here, but I also have a fellow podcaster, which is nice because you came in prepared, you have your microphone, you're checking audio and giving tips, so it's it makes the life easier, yeah, because you know what we do, so it's like a so it is, it's definitely great having you both here, and I appreciate the time. So as we come to an end, is there anything else that you have to add about this or anything else?
I don't think so. I think we covered a lot of ground. I was thinking about this coming in of what fun stories do I want to tell of all the stuff we've accomplished in the past year. I think I covered all of them. So there's a ton more examples,
Honestly,
but
if you're a microbiologist, just like hang out with ID pharmacy.
yes,
I don't
and
think
vice
I've
versa.
met an ID pharmacist that I didn't learn an absolute boatload from. Like I just think they're really cool, and I don't dose drugs, so I'm so glad they do that.
And I feel the same about microbiologists. You guys are very, very, very cool. So
Yeah. No, I love when people come in the lab and as I said, all the positive things that come of it and understanding what we do. And unfortunately, sometimes, we get reduced a little bit to the more negative effect. Why is not my culture ready? Why my susceptibility report is not done? What is taking so long down there? So coming in and seeing what the work is and having a better understanding is definitely beneficial. So, well, once again, well, this has been so great, and thank you both for taking the time to be in Let's Talk Micro. Well, that was the conclusion. I hope you enjoyed it, and if you haven't checked out the previous one, I invite you to do so. It is a great conversation with Hannah and Erin, so definitely check them out. And as you know, Let's Talk Micro is on all podcast platforms. You can find us on Apple, Spotify, Amazon Music, Good Pods. So wherever you listen to podcasts, you can find Let's Talk Micro. So I invite you to subscribe to the podcast, download episodes, and if the app allows you to do so, please go ahead and leave a review. As always, I'm thankful for the support, and you can find us on socials on Instagram, TikTok, YouTube, and Blue Sky Social as Let's Talk Micro, on X as Let's Talk Micro 1, on LinkedIn as Luis Plaza, and there's the email address letstalkmicro@outlook.com, and there's also the website letstalkmicro.com, where you can find resources for studying, and there are also episode updates. So I invite you to subscribe to the website. If you want to support us in any way, you can do so via a Venmo link or via Buy Me a Coffee, KOFI, both links available on the show notes. If you are looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book, available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. And these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And as you know, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. Hey, and one thing that I wanted to let you know is that I'll be attending ID Week in Atlanta, Georgia from October 19th through the 22nd. So if you're attending and you see me, hey, stop me, say hello. I'm looking forward to connecting with you. And that, my dear audience, it's the end of this episode. I hope you enjoyed listening to part 2. of the collaborations episode between stewardship teams and the microlab. As always, I enjoy sharing this information with you. I am so thankful for your support. Thank you for taking the time to listen and downloading episodes. I am so grateful. And please, continue bringing that passion to what you do. It's so important. You do such great work. As I said, if you're attending ID Week, October 19th through the 22nd, stop, you see me, stop by, say hello. I'm looking forward to meeting you and connecting with you. As always, stay tuned. Great things coming your way. But as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.